Welcome back to our Ultrasound Case of the Month series. Feel free to comment below and I will attempt to address any questions or concerns. This case was evaluated by the resident Dr. Clayman and her attending Dr. Doggett. The case starts with a 31-year-old female presenting to the emergency department with acute onset of lower abdominal pain that started 90 minutes prior to arrival. The patient reported being pregnant yet was unclear in her dating. Her vitals obtained in triage were largely within normal limits. On examination, she was comfortable yet did have slight tenderness to palpation of the bilateral lower quadrants. As urine and labs were obtained, the treatment team utilized bedside ultrasound to capture the following images. This is the first image obtained. Take a second to attempt identification of important structures. I will clue you in that the imaging is obtained in the suprapubic region. Hopefully you were able to determine that this is a sagittal cut through the uterus and bladder obtained with the probe marker oriented to the patient's head. The uterus is the most readily identifiable structure and I've highlighted it in red. The uterus as well as the transition of cervix and vaginal stripe can be seen. The bladder highlighted in yellow sits in its classic position for sagittal imaging. The probe was subsequently rotated toward the patient's right to obtain a transverse view through the uterus. Once again, take a second to appreciate relevant anatomy. The bladder can be visualized just deep to the uterus and has once again been highlighted in yellow. Like with all imaging studies, it's important to focus upon the entire picture, not just the easily identifiable structures. Once we start looking at structures other than the uterus and bladder, we see an abnormal structure in the patient's right adnexal, which I highlighted in blue. The treatment team subsequently zoomed in and focused on this structure to assist in identification. Hopefully you can see that this structure is separate and outside the uterus, which can be seen just to its right. The abnormal adnexal structure is again highlighted in blue for easier identification. While I'd like to say these pictures are diagnostic, there is no way to give a definitive diagnosis based on these images. However, when the labs resulted with a beta HCG of 35,000, the team's already present concern for an ectopic increased substantially. A radiology performed transvaginal ultrasound was subsequently completed. For those of you newer to ultrasound, you can identify this as a screenshot from a transvaginal ultrasound based upon the shape of the probe at the top of the image, as well as the higher resolution offered by the higher frequency probe. In this clip, a sagittal or long axis view of the uterus is identified. Similar to the transabdominal images, no evidence of an intrauterine pregnancy is identified within the uterus, which I highlighted in red for easier identification. The probe was subsequently rotated to the patient's right, giving a transverse appearance to the uterus. No free fluid or concerning abnormality is identified. Again, no structure within the uterus is identified to represent an intrauterine pregnancy. In this orientation, the more circular appearance of the transverse uterus is highlighted in red. After imaging the uterus, the adnexa were farther evaluated. In this short video, the operator fans lateral to medial, starting at the tubular appearing iliac vessels, which are often considered the lateral border of pelvic ultrasound. As the operator fans medial, a distinct abnormal adnexal structure with a gestational sac and fetal pole is identified. Here's a still shot showing this abnormal adnexal structure, which more clearly shows the gestational sac and fetal pole. While not shown, a heart flicker was identified. These findings confirm the diagnosis of an ectopic pregnancy. When comparing the transvaginal versus transabdominal views, the resolution difference between the two is remarkable. The clarity offered by the transvaginal ultrasound is secondary to the lack of tissue attenuation, along with the higher frequency property of the probe. Mastery of transvaginal imaging is surprisingly easy, and I encourage learning the skill given the improved information the modality offers. Given the diagnosis of an ectopic pregnancy, the OB service was consulted. Luckily, the patient was well appearing with stable vital signs without evidence of rupture. After evaluation, the patient was consented for surgery. In the OR, the ectopic pregnancy was identified and a laparoscopic right sublumpectomy was performed. The procedure was tolerated well and the patient was discharged after an uneventful course. I like this case because it provides a chance to review the workup of a patient presentation that we all see nearly every shift. Additionally, it gives me the opportunity to review some incredibly important topics that I find are not well appreciated by many providers evaluating these pregnant patients presenting the first trimester with pain or bleeding. First, and I can't state this enough, an intrauterine pregnancy is a gestational sac plus either a fetal pole or yolk sac. A gestational sac by itself is not enough to presume the presence of an IUP. A gestational sac alone is not enough because it could represent a pseudogestational sac, which is an endometrial reaction that can occur with an ectopic pregnancy. Transvaginal ultrasound provides a valuable resource to identify the yolk sac or fetal pole, especially early in pregnancy where these structures are difficult to visualize on transabdominal ultrasound. Identification of an IUP largely rules out the likelihood of ectopic depending on patient-specific factors. The other piece of the puzzle that often leads to confusion is the beta HCG level. Sadly, reliance upon beta levels tends to be more historic than evidence-based. The threshold or discriminatory zone tends to be an institutionally dependent level, classically ranging from 2,000 to 3,000. However, ACOG has advocated for conservatively high values as high as 3,500 to avoid misdiagnosis and possible interruption of normal pregnancy. The discriminatory threshold represents a level at which you would expect to visualize an IUP in the majority of normal pregnancies on transvaginal ultrasound. Utilizing a single beta in the discriminatory threshold is not perfect, and I like this quote from ACOG stating, "Serum HCG values alone should not be used to diagnose an ectopic pregnancy and should be correlated with the patient's history and symptoms and ultrasound findings because it implies the imperfect nature of these presentations. You as the clinician must incorporate multiple factors into the decision that is best for your patient, and I would advise a low threshold to talk to your OB colleagues in cases of uncertainty. The vast majority of these patients require a repeat evaluation in 48 hours to turn the beta level and provide some degree of clarification to the single value and what it represents. I wanted to provide a case example because this is a presentation we all commonly encounter, yet management varies. You encounter a 28-year-old female presenting because of lower abdominal pain and spotting who reports a positive home pregnancy test. Triage obtains labs and her beta is 960. What do you do for this patient? Some providers incorrectly assume that no ultrasound is indicated because the beta is below the discriminatory threshold and subsequently no IUP is likely to be seen. However, ectopic pregnancies are abnormal and do not follow the beta levels expected for a normal pregnancy. Some references even say as high as 50% of ectopic pregnancies present with a beta less than 1,000. An ectopic can occur at any beta level. As I previously stated, almost 50% of ectopics present with a beta level below 1,000. You should not be reassured by a low beta level, and in my opinion, a workup with ultrasound is indicated. In summary, hopefully I've laid out why utilizing ultrasound for the evaluation of first trimester pregnancy pain and bleeding is the standard of care in the emergency department and our main roles throughout ectopic pregnancy. An IUP is a gestational sac plus either yolk sac or fetal pole, and once identified, the risk of a heterotopic is quite low, unless the patient has undergone in vitro fertilization. Additionally, don't be fooled by a pseudogestational sac. Finally, beta HCG interpretation is nuanced and not perfect, which necessitates taking other patient-specific factors into consideration to provide the best plan for the patient. Please understand how discriminatory thresholds are utilized and that ectopic pregnancies can often present at beta levels below these thresholds. Thanks for watching and feel free to comment below.